Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. It is the 186th episode of the Codecast, and today's episode, I wanted to bring to your attention a CMS alert that came out this morning, and it was regarding the new auditing for the 20% bump in payments that hospitals received when the patient was discharged as COVID positive. And so during their stay, they weren't discharged necessarily with COVID, but that was the primary diagnosis that was put in their chart as a point of service. And so some of you may not be aware of this OIG rule that happened in the last 6 months. And I did write an article about this in ICD-10 Monitor, I think October of last year, where I knew it was coming. I knew the oversight committee with HHS was, definitely going to look into this because of how the first direction came out on how to diagnose patients with COVID. And so what happened is that at the beginning, and many of you know this because my head exploded last year, is they were saying that, anybody who was suspected COVID or the doctor felt that they had COVID, even with a negative test, they could diagnose them with COVID. And I was like, wait a minute. Why would you diagnose them with COVID if the test was negative? And they're like, oh, there's a lot of false negatives or false positives or whatever. And I'm like, wait a minute. So there's only false negatives. There's not false positives, as we've seen a lot, especially in professional sports, because as soon as somebody got a positive test and couldn't play for a couple weeks, mostly the marquee players, they were like, well, let's keep testing them every single day till it comes out negative. And so this is where it was really kind of interesting just to see how it all panned out. So what's happened is that there's been some new OIG WorkPlan additions. And what the HHS-OIG said is that they're going to investigate whether hospitals billed for the 20% add-on Medicare payment for COVID-19 discharges correctly. And that's what's on the new WorkPlan. And so what happened last year was that the Medicare payments made to hospitals for COVID discharges that qualified for a 20% add-on payment under the CARES Act, that's the Corona Aid, Relief, and Economic Security Act. What they did is basically they would give them extra money, no matter how many people say, oh, they didn't make money on coronavirus. Yes, they did. They made an extra 20% when a patient had a positive outcome for that. So the reason they put it on their work plan, and this is just the weird, interesting part of this, is because you have to have a positive test, actual positive test, to get the 20% add-on payment, not just a positive outcome. And that's a recent CMS requirement that there has to be some kind of positive laboratory test. And that was September 1st, 2020. A MedLearn Matters article talked about, admissions occurring on or after September 1st, 2020 would have to have a positive COVID-19 lab test documented in the patient's medical record in order to qualify for the add-on payment. And that claims that cannot support a COVID diagnosis with a positive test within 14 days of hospital admission will be subject to post-payment review and potential payment recoupment. And what's hard about that is because, again, they told hospitals and physicians that if you look at a patient and you think, and based on your decision-making process, that the patient has COVID, regardless of the testing, that you can bill it that way. Well, this has not helped providers at all understand how to code correctly for COVID care, because it was very confusing as far as what they were allowed to bill and what they weren't allowed to bill. And so what's happening, I'm noticing, is that CMS is starting to go back on what they said and the advice that CDC gave to the AHA, who gives advice on, what should be published for diagnosis codes. And basically they're saying, well, we're going to revise our policies, our standards, and we're going to give you frequent updates to these policy and what we want documented but they didn't say it at the beginning. So it's basically like you start your job with a certain job description, and then midway through your job, you're given an updated job description, and it says, oh, you missed 15 through 20 that wasn't on that to begin with, if you had 1 through 15. And basically they're saying, well, your first 6 months of your job, you didn't get the last 5 on there. Say, but I didn't have that information. You said this, and now you're saying this. So there's a lot of confusion over what the blanket waivers cover versus what happens under specific waivers, also that the governors have put out as well. And so what needs to be documented? Well, the federal government, the HHS-OIG, has said that there has to be a positive lab test for any patient admitted after September 1st, 2020, for COVID to be able to get that 20% bump in recoupment. If not, then they're going to come back, or I should say bump in payment. If it's not documented that way within the patient's chart, then the recoupment is going to come, meaning a request for refunds. So if you are a hospital staff or you're a hospital employee, you need to make sure, especially in the coding and billing or administrative area, you need to make sure that you bring that to the attention of your superiors so that they understand what's happening with all of these recoupments. Another thing that's happened is that CMS resumed RAC audits and other medical review activities. And so they were put on pause because of COVID, but I mentioned before that a lot of the audits started back up on August 3rd, mostly with hospitals. I want you to make sure you're aware of that, because remember, over $50 billion in coronavirus relief funds were given to providers. And they're like, okay, now you're complaining that you don't have any money. So where did that go? And so now CMS is resuming these audits, and again, during the pandemic, which surprises me, but you're going to have to make sure that you are prepared for it, that you have the staff for it. And it's really going to also challenge, because I know some of you are still dealing with some Medicare appeals backlog, trying to deal with just some of the delays. Not only did a lot of staff members pivot back to working from home, but so did a lot of the payers. And so it's been tough to try to get paid on certain things. And then also with resuming the MAC and RAC initiated audits, this could dampen, I'm thinking, the HHS progress in Medicare appeals backlog. And so we're really trying to figure out what's going on right now. There seems to be a little bit of chaos at CMS, and I just wanted you to be aware of that, because there's so many, waivers and flexibilities and, these nationwide thing that they've put out to help out. And they say, oh, by the way, all this stuff that we've given you, now we're going to go back and check on it to make sure that it was accurate. And I understand that you have to have oversight, but it would be nice if the oversight came with clear direction at the beginning, so you knew how to code it and bill it where you were protected when the audit started back up. So it's kind of like being told that, well, you can try it, but you take your chances. And I don't think you can take your chances was actually clear when this first happened. So this is where it gets a little bit dicey, because I think a lot of providers, especially hospitals, that were told that, a physician can just say, oh yeah, they have COVID, when they actually weren't tested positive for COVID. They just had a respiratory infection. And I think this is going to become a problem. I had insight to this last year only because it just didn't make sense to me to be able to code something that you didn't have proof. I mean, I've been a coder for over 30 years, certified now for, 27 years. And it's a weird concept to not say, okay, or to assumptive code that you have to have proof for something. And now they're coming back and saying, well, that's what we meant to say. So be aware of that in your scenarios, because I'm assuming that there's going to be some widespread requests for refunds, especially in the hospital situation. Okay, so let's take a look here, and I want to talk to you about a coding question. But first, Today, the Codecast podcast is also brought to you by JP Morgan Private Bank. Connect with over 200 years of experience, service, and stability. JP Morgan Securities, JP Morgan Chase Bank, privatebank.jpmorgan.com. So I've had a question pop up quite a bit lately, and I wanted to talk to you about it, and it's the 99000. For those of you that don't know what that is, many of you probably haven't even coded for it because it's rarely paid, and it has no relative value units with Medicare. It commands $0 in the Medicare non-facility fees. But the 99000 is found in the miscellaneous section of the CPT book. And it says handling and or conveyance of specimen for transfer from the office to laboratory. And it's getting a lot of attention lately because of miscommunication on what you can report and what you can't. So when in March 2020, when the AMA released its recommendations on reporting, they basically said, if you meet the requirements for 99000, you should code for this. Well, remember when the pandemic first happened, sometime around August of last year, we got an update from Medicare and AMA saying that we could use the nurse visit for any of the time counseling a patient and also helping with the lab test if you're testing a patient. Well, the 99000, basically what it is and what it isn't. Okay, so it involves any work your practice has to perform and prepare a specimen for transportation to a lab. And then it's per the agreement your practice has with that lab. And it could include separating a fluid layer using a centrifuge or filling out paperwork required by the lab, maybe labeling and packaging the specimen per the lab's instructions. But costs incurred by your practice to transport the specimen to the lab or any costs that are not already absorbed by the lab. So for example, if your practice uses a courier service to transport a specimen from your office to an outside lab and your practice pays the courier, then in this scenario, 99000 would be your code for covered expenses. If the lab comes to your practice and picks up the specimen, like LabCorp does, and the expense for the transportation is folded into the lab's fee for the service, then you can't use 99000. But remember, it's not just for transportation costs. It is also for some of the work performed that isn't already included, let's say, in a venipuncture code, the 36415. The problem is that it has a B status with Medicare. You're going to see on occasion, I'm starting to see certain Medicaid plans say, okay, during the public health emergency, we'll pay for it. But be careful with all of a sudden bringing this back to your physician saying, look what we can get, $4 for. Be cautioned about that because just like telehealth, just like some of the services that are being allowed during the public health emergency, they're going to be yanked back away from you once the emergency's up. And Medicare, again, doesn't pay for it. The second thing is, let's say you bill it to a Blue Cross payer who doesn't pay for it and it's a non-covered service, but you bill it to a Medicaid plan that is covered because you've decided you're going to bill it to everybody. And you can't report it to Medicare if it's bundled. But here's the thing, if it gets denied not for contract issues, but because it's a non-covered service, you actually have to bill the patient. It's just not something that's covered. It would be like billing for after hours care, that extra add-on code, 99050. If you're going to bill something, remember you're billing it with the intent that you expect to get paid, not that you hope to get paid only from a payer. So patients will have an out-of-pocket or share of cost if you're not paid. And if you're only billing something to see if the insurance company pays you, then that's a red flag for fraudulent practices when it comes to how you submit your claims. And you can get into a lot of trouble for that. So it's not necessarily, can you, it's should you bill for it. If you can justify the expense for that particular patient and you're also ready to charge the patient if their commercial plan doesn't pay, then I'm going to make that your call. But when you try to code for the 99000, just remember, Medicare for the most part Medicare doesn't pay for that, but Medicaid, only some of them pay for that. So you have to be a little bit careful because there was a footnote on something I read recently. I was trying to go back and figure out if there was any kind of special fraud alert on it. Well, there was in the OIG special report. It was a footnote tucked away in the June 25th, 2014 special fraud alert special report on laboratory payments to referring physicians. And it talked about, even though physicians are not directly reimbursed for this code as they are for 36145, they may choose to report this as costs associated with these services. However, it has to be calculated in the practice expense component. It has to reflect extra expense to the practice, and it's to any payer that, including the patient, that would have to pay for this expense. So this is where you have to really do your due diligence to find out if it's okay. And I'm just seeing this pop up all over the place. I'm getting all kinds of questions about it. Now, in workers' compensation, for those of you that do that, that's a little different. Remember, that's not a HIPAA entity. So, for example, Michigan workers' comp, they pay $5 for it. Colorado used to pay $2 for it. Then they went up to $25, and now they say we're not paying for it anymore. We follow Medicare rules. California definitely doesn't pay for it. And the state of Wisconsin Medicare program, they say we will only reimburse for it, and it's actually their local MAC carrier, when a blood sample is sent to a lab for lead testing and it is not analyzed on site. So they have this big rule if they're going to pay for it, and no handling or transportation costs are involved. So really make sure you know if that is appropriate or when. But if you were going to ask my advice on it, I would say probably not bill it. Otherwise, you're going to be just writing it off, I would say 90% of the time. So those of you that have had success with it, that's great. I wouldn't have you change what you're doing. But just be cautioned that it is bundled with Medicare. It's not covered by most payers. And I liken it to you trying to charge for head paper in your exam room, or trying to charge for a patient's gown. These extra costs that are built into the cost of doing business. And so you're already getting paid for, the administration, you're getting paid for a finger stick, you're getting paid for the blood draw. If you have your in-office lab, you're getting paid for certain things that include this. So try not to get crazy and bill for things outside of what's considered just part of that. Otherwise, that can just be a nightmare. I also had a compliance question that I wanted to bring up this week. And this was, Terry, our patients frequently ask if we can send them appointment reminders or bills via email. However, we are currently not equipped with secure email. Is that a violation of HIPAA to communicate with patients this way? So according to the HHS, so the U.S. Department of Health and Human Services, that is the Oversight Committee for Medicare, what they say is, yes, you can communicate with patients via unsecured email, but you will have to make sure you've taken the following precautions before you do. So first, you have to make sure that you've applied reasonable safeguards before electronically communicating with the patient. That includes taking every step to verify the patient's email address, including sending an email alert to the patient for address confirmation prior to sending the message. The HHS also suggests you limit the amount or type of information disclosed through unencrypted email. Second, you must abide by the patient's wishes regarding this kind of communication. So if a patient wants to use unsecured email to receive appointment reminder, you can do so, but alternatively, if the patient does not want to use this to receive communications, you must provide an alternative communication method. If they want it to be through text, then you have to get their permission. Again, have these forms written up and signed by the patient. But just make sure you're heeding the advice from HHS to make sure that you're alerting the patient to any risks inherent to unsecured email communication or electronic communication before agreeing to do anything like that. It's just a really big deal, especially with some of the flexibilities, and now that patients want to do everything electronically. So just make sure that you're covered on that. So I hope everyone had a great Mother's Day weekend. My personal tidbit this week is we found Summer her wedding gown this weekend, shoes and veil. Yes, I cried, and I am not a sappy person, but I'm so happy we got the most important part handled. Now I think it's going to take me 10 months to figure out what I'm wearing, because for those of you that know me, and I know many of my listeners have come to a live conference or a seminar with me before, I do not wear dresses for anybody, not even a wedding. It's just not me. So this will be interesting to see what I come up with. Who knows? Just my daughter's like, just wear something that's nice. So I'm like, okay, so it's just kind of figure out what it, of course it's going to be nice, you silly girl. Anyway, that's it for me this week, folks. Make it a great day, and I'll talk to you next week on the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terrycoder1.com. www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.